So I'm delighted to share this special day with everybody. We've heard how important it is for all of us. My lab focuses on psychotic symptoms, the symptoms that are characterized by a profound departure from consensual reality. People believe things that others in their families and friendship groups don't believe, and they perceive things that other people don't perceive. What we focus on is trying to sort of draw on the reductionist or basic neuroscience that's going on one side of the corridor at the CMHC and applying it to these very deep and profound clinical problems that we're faced with. It's always good to start with some definitions. Delusions are fixed false beliefs that aren't amenable to change in light of conflicting evidence. What the lab focuses on is to try and understand something about healthy belief formation and apply what we learned there to the problem of delusions. This is an example of the Capgras delusion. It was first reported in Paris in the 1800s by a neurologist. This is a 74-year-old lady who believes that her husband, rather like the invasion of the body snatchers, has been replaced by another unrelated man. And critically, this drives her action. So she refuses to sleep in the same room as the imposter. She locks herself in her room at night, and she asks her son for a gun to protect herself. Now, I want to be very clear. People with mental illnesses are 14 times more likely to be the victims of violence than the perpetrators, but nevertheless, this is a very distressing experience for the person herself and for her family members. So I think there's a real impetus to understanding what's going on here. The definition of hallucinations is much more simple. Perceptions without an external stimulus in the world occurring when people are conscious and awake and having the qualities of real perceptions. Here's an example. This is a young man from the UK. When he goes away to university, he starts to notice that there are voices in his head commenting on his actions. And he seems to put this together with a sort of delusion-like idea that perhaps those voices are happening because of MI5 security agents, the government organization that James Bond is part of. They're plotting to kill him, and they're really tormenting him. I think, and what the lab has been working on trying to demonstrate, is that both of these symptoms may be understood from a really, really basic reductionist point of view in terms of Pavlovian conditioning, which I'm sure you're all familiar with. This is the idea that animals associate stimuli out in the world, like this ticking metronome, with the presence or prediction of really important events, like the delivery of food. So much so that over time, the metronome, the sensory stimulus, comes to represent and predict and bring forth in the animal's mind that food is about to arrive. We think that beliefs about causes and effects might arise in exactly the same way, and we think that perceptions, too, might arise in the same way. That is, things out in the world that happen to occur together with one another tend to be associated in our minds, and that perhaps delusions and hallucinations are driven by that process going awry. This is a very overly complicated and mathematical way of describing that process. It's called the Rescorla and Wagner learning rule. It was actually developed at Yale in the 1970s by two psychologists, Bob Rescorla and Alan Wagner. And it basically says that we learn from our mistakes, and we learn most, we form new beliefs most in situations when our mistakes are largest. The term in here that's really, really important is the one at the end in brackets. It represents the mismatch between what you expect to happen in a given situation and what you actually experience. We think that people with psychotic illnesses, people with hallucinations and delusions, have this signal in their brains in response to events that really ought not to be surprising. That makes them attend to things that everybody else might ignore, and it makes them learn about those things and form beliefs about them. I'm going to show you some data that will hopefully convince you of that fact. This is the type of task that we expose people to whilst they're in the fMRI scanner, whilst we take pictures of their brains. We ask them to imagine that they're an allergist, and their job is to figure out the cause of allergic reactions in a new patient that's just been presented to them. So they see that he's eaten a hamburger, and they see that he has an allergic reaction every time he eats the hamburger. Now, we show them that hamburger paired together with bananas causes an allergic reaction of exactly the same magnitude. Now, according to our equation, there's no prediction error here, right? Everything's already predicted by the presence of the hamburger. There's nothing new to learn about the bananas. If you have a brain that's signaling prediction error signals when it really ought not to, I would imagine that you might attend to and learn something about the bananas. And in an experiment conducted with an incredibly talented psychiatry resident, now a fellow in the psychiatry department, that's exactly what we tested. We went to the psychiatric emergency room, we took our laptops, and we tested patients who were there. The controls in this case aren't people without mental illness, they're people without a psychotic mental illness. These people can learn the appropriate expectations in our task. They learn that the hamburger causes the allergy and the bananas don't cause the allergy. But people who are there for psychotic reasons, people who have hallucinations and delusions, tend to learn too much about the bananas. So some behavioral evidence that this prediction error mechanism might be going awry in patients with a psychotic illness. As I said, we can also do this in the fMRI scanner. And when we violate people's expectation, when we show the banana causing the allergy, if they're healthy controls without psychosis, this region of right dorsolateral prefrontal cortex seems to be very engaged. It seems to reflect the presence of that prediction error signal from our equation at the beginning. However, if you're someone with first episode psychosis, your brain is engaged to events that really ought not to be surprising. And the more that's the case, the more severe the derangement of the functioning of this particular region, the more severe people's delusions are across subjects. In order to understand the neurobiology of this effect, we can model some of the early phases of psychosis with ketamine. This is a drug you've heard about already. It has these miraculous effects on depression, but it also causes people to have some odd and unusual experiences, and this is another avenue in which this drug might be incredibly helpful. When we give this to healthy people, we know its mechanism. We know that it drives up glutamate release in the cortex, particularly in that region of right dorsolateral prefrontal cortex. And when we do that, people have odd and unusual experiences. Like this person. Every time I left the room, she thought another person was coming into the room dressed in my clothes, doing my job, a little older in age and weighing a bit more. I think this is something that's certainly happened to me since I've been at Yale, but not on that particular time scale. Kind of redolent of what happened to the 74-year-old lady in my initial example, perhaps an example of experimentally induced Capgras delusion. When we give people ketamine and have them do exactly the same task that I just described to you, you'll see that people's responses look exactly like people with first episode psychosis. That is, their brains are inappropriately engaged in exactly the same region whilst they're on ketamine. And just like in first episode patients, the more that happens, the more severe those delusion-like experiences are. So we're really starting to get an experimental handle on where these symptoms might be coming from. And it gives us some clues about what we might be able to do to intervene. I want to change gears and talk about hallucinations now. The beliefs that I've just told you about can really change what you perceive about the world. This is one of my favorite quotes from Karl Jaspers, who's probably the father of modern psychopathology. He says, once you have a delusion, it permeates everything else that you experience. This happens to all of us. One of the things John talked about earlier is stigma. I think what my work is suggesting, and the work in the lab is suggesting, is that we're all susceptible to these sorts of odd experiences. It's not that people that have psychosis are a different species. Everything occurs on a continuum. And I'm going to show you that now. So what you can see on the screen here is a rotating...
This is the hollow head. Oh. Actually, at the moment, it's a perfectly normal head of Charlie.
That guy's got a much better British accent than mine. So what you can see now is a rotating hollow mask of Charlie Chaplin's face. And as you start to see the inside of the mask, you're going to see something unusual start to happen. Did you notice? Did you see it? I'm going to let it keep running because it's kind of a profound experience, and I hope it's educational to you. Your beliefs about faces, that they always point outwards, your beliefs about how light falls on a face, cause the perceptual inputs that are coming through your eyes to be overridden by your brain. That's exactly what we think is happening with people who are suffering from hallucinations. I'll just show you one more time, just so you can see. Did you notice? It flips direction? Okay. Now, we wanted to try and operationalize that in the lab, and we did so with a really old paradigm. It's actually developed at Yale in the 1800s, but this is an example from Stanford in the 1940s, much more similar to what we actually did in the scanner. We can present people with perceptual stimuli, just like the bells and metronomes that I showed you at the beginning. In this case, it's a bulb that illuminates, followed by a very near threshold, very hard to hear tone. If you pair those two stimuli over and over again, so much so that every time the subject sees a bulb illuminated, they expect to hear a tone, we can encourage people to believe that they heard tones that we never actually presented to them. And we wanted to port this experiment into the noisy fMRI scanner. And we did so by pairing the presence of a checkerboard stimulus with an auditory tone that's played very, very near to threshold. And we did that over and over again, and eventually we showed them the checkerboard and then didn't play a tone, and we looked at what happened inside people's brains when that was occurring. This is work that was conducted with Albert Powers, who's a fellow in the psychiatry department. We wanted to explore this idea that psychotic experiences occur on a continuum. And so we recruited a group of healthy people who have neither a diagnosis nor hallucinations. They're the people in the white box. We recruited a group of people who have a psychotic illness like schizophrenia and do hear voices. They're the people in the purple box. We recruited a group of people who have psychosis but no hallucinations. They're the people in the red box. And we had a sort of unusual idea that we might be able to find some people out there in the community who were non-clinical voice hearers, something that would resonate with the Hearing Voices movement that I know is very influential here in New Haven and in the US more broadly. And we hit upon the idea that we might be able to recruit some clairaudient psychics, people who hear daily voices inside their head but don't have need for clinical services and indeed are somewhat flourishing as a result of their experiences. That's not to say I don't take the hallucinations seriously, but I think they provide a really interesting control group that can tell us really what it is that's pathological and that might need treatment with regards to people who do have a diagnosis. When we ran these people through our task, the results were quite profound. You can see that anybody who hears a voice is much, much more susceptible to our behavioral effect, almost as if we've developed a hearing test for whether people hear voices. Just to collapse across those two bars, if you hear voices in your head, you're much, much more likely to show this behavioral effect in our really simple cognitive task. Just to show you that those effects really draw themselves out at lower levels of auditory stimulation. We varied the intensity of the tones during the task, which I didn't mention earlier, but you can see the groups really pull apart at those lower intensities when it's really very hard to hear the tones. Your perception is much more being driven by your expectation about what's happening in the task, and people who hear voices are much more susceptible to that effect. The susceptibility correlates with the severity of the symptoms that people experience, so more voices in your head, you're more likely to show the behavioral effect. When we scan people's brains at the beginning of the task, just simply listening to the tones, no conditioning here, we see a really nice and predictable and sort of reassuring effect that tones of different intensities engage the auditory cortex. But we then took those regions of interest in the auditory cortex through to our task and asked the question of the data, are there regions of the brain whose activity is instantiating these conditioned hallucinations? Are these same regions active when people report hearing tones that we didn't actually present to them? And again, there's a really robust and significant effect here. When people report tones that we didn't present them in the context of the task, that region that's tone sensitive is hyperactive and inappropriately engaged. So again, an objective test that people are hearing something in the context of our task that we didn't actually present to them. When we look more broadly in the brain, there's a circuit of regions, including the anterior insular cortex and the anterior cingulate, as well as dopamine-rich regions in the midbrain and the basal ganglia. Those are the regions that our traditional antipsychotic drugs seem to act on, those midbrain and basal ganglia regions. But we've identified a cortical circuit more broadly that may be interesting with regards to developing new interventions. Quite pleasingly, there's an overlap between the data when people lay in the scanner and just push buttons whenever they're hearing voices. This is a meta-analysis of thousands of those cases. And you can see that our data really overlap in a really nice way, a really convincing way, between people sort of indicating that they're hearing voices in the scanner and the circuit that's engaged when we operationally and reliably engender those experiences in the context of the scanner. So we think we're in the right area, and we think we're dealing with something that's incredibly clinically relevant. Now, we used a computational model. I'm not going to go into the details, but the model identifies layers of different beliefs. It identifies, did you believe that tones happened in the context of the task? Did you believe that those tones were predicted by the visual stimuli? And did you believe that that association could change over time? And we compared people's beliefs across these different levels, across our different groups. And what we found was people that hear voices in their head are much more likely to weight their perceptual decisions towards their prior expectations, significantly so. They're also much more likely to believe that tones happened in the context of the task. We already showed you that. That's not particularly surprising. However, our clinical voice hearers and our non-clinical voice hearers diverged at this upper level of the model. So people who were psychics, people who didn't need a clinical attention, were much more able to update their beliefs flexibly in light of new evidence as the task proceeded. People with clinical voices tended to jump to perceptual conclusions and stick with those conclusions throughout the task. And when we regress those data back onto the brain, what we find is that there are different circuits within that overall circuit that correlate with these different mechanisms. So much so that perhaps there are regions that we might be able to intervene on and target. And the way that we can do that is using a technique that we've already heard a little bit about this morning, transcranial magnetic stimulation. It's FDA approved to treat depression. It uses a very rapidly switching magnetic field that, according to Faraday's law, induces a current in the neurons that are near to the surface of the brain. Depending on the pattern of stimulation that you use, you can either increase or decrease activity in that region. And based on our data, you might imagine that we want to decrease activity in auditory cortex, and that might help people who are hearing voices in their heads. This is just some data from a very basic study, actually conducted in gerbils, showing that when you give exactly this pattern of stimulation, 1 hertz, rapidly fluctuating transcranial magnetic stimulation, you can reduce the neural activity in auditory cortex in response to a particular input. So that's exactly what we tried to do in people with intractable hallucinations. And when we did that daily for 4 weeks, we were able to significantly reduce the severity of their voice hearing, but also the severity of all the other psychotic symptoms that they experienced. So this wasn't just something specific to hallucinations. It tended to produce overall changes in negative symptoms, in delusions, and actually in their cognitive performance too. So people who went through this stimulation procedure actually had improvements in their working memory and in their verbal memory too. 2 domains cognitively that people with psychotic illnesses also seem to struggle with, and actually domains that tend to predict functioning in everyday life. So we're really encouraged by the effects of this stimulation. We scanned people's brains before we gave them the stimulation and then again afterwards. And what I'm showing you here is the differences in the connectivity of regions of the brain having gone through this 4 weeks of TMS treatment. And I'll just highlight some interesting observations. The things I've ringed in red, whose connectivity is altering as a function of going through the TMS, is exactly the same circuit that's engaged by our task. Regions of the cerebellum, the midbrain, the basal ganglia, and the anterior insula. And in blue, what we're showing here are regions of the brain whose activity and whose connectivity to the rest of the brain reduces as a function of TMS. You note that that region is the same region that was hyper-engaged during our delusion study earlier on. And interestingly, these changes correlate across subjects with the changes in symptom severity. So we think we're honing in on a very specific change in the brain that's mediating this change in these very distressing and troubling auditory hallucinations that people experience. I'm going to stop there and summarize what I've told you. Predictions about the world are really, really important to all of our cognitive functions. Early in psychotic illness, people's predictions might fail so that things seem surprising and significant and important, and that delusions, and to some extent hallucinations too, might form and maintain in order to explain what's happening. We've been able to model some of those processes with ketamine, giving us some clues about the underlying neurobiology of these symptoms. I've shown you a computational model that might help us understand some of these experiences and symptoms. And I've shown you how, in a preliminary study, we've been able to treat those things with transcranial magnetic stimulation. I think the next phase in our TMS work is to implement a really good placebo control. We have a new coil in the lab that can make all of the right sounds, but not actually deliver the magnetic pulses. We have a TENS machine that can induce muscular twitches on the scalp so that somebody can come into the study and not know the difference between getting active and inactive TMS. That's a key phase in pushing this forward as a new treatment for psychotic symptoms, and it's something we're actively engaged in. Thank you so much for your time. It's been a real honor to share this work with you. I just want to point out again the two people that really pushed this work forward, the two psychiatry residents, Sarah Feinberg and Al Powers, but also highlight the whole team of people that have been involved in this work. And thank you for your attention. I'd be delighted to answer any questions. So with the people that we've been able to stay in contact with, they actually last for up to a year, and they're still ongoing. I actually met with one of the subjects in San Diego at a conference recently, and she's now going to college and doing much, much better than she did when she was in the context of the study. I haven't done any statistical analyses, but the anecdotal information is that it seems to last when it works. Hi. So right now, I can't personally, because I'm not a psychiatrist, I'm not a clinician, I'm a cognitive neuroscientist. Perhaps some of the other psychiatrists can talk about that. But this is an experimental medicine study. So I'm not suggesting that this is ready for prime time at all yet. And I can't speak to reimbursement, I'm afraid, sorry.
Excuse me.
Hi.
Is there any comparison between TMS and electroshock therapy in effectiveness? Or is it individual?
So the way that we do this particular intervention is much more targeted to the individual's neurobiology, right? So we find the region of auditory cortex that's hyperexcited. ECT seems to be a more broad-based intervention. I know that ECT can be effective against psychotic symptoms, but we haven't done that comparison in the lab yet, no.
Okay, thank you.
Sure. Hi.
Were these subjects on medication, and if so, were they weaned off after the treatment?
No, so, well, I don't know about afterwards. So they were on medication, and we maintained their meds throughout the course of the 4-week study. I should have mentioned that, I'm sorry. However, they were still really severely hallucinating and experiencing these voices at least 20 times a day. Very intrusive. Again, we followed up with quite a few of the subjects, and they do seem to have been able to at least reduce some of the meds that they've been taking, but I don't have data on that to sort of show you an analysis. Hi.
My question is not exactly on your topic, but it may be able to answer.
Sure.
I recently heard about a study being done by Dr. Robert Friedman on choline in the second and third trimesters of women's pregnancy. Choline is some kind of vitamin or nutrient, and the testing is occurring now, and they're following these kids who were born, and they think they may be able to prevent schizophrenia. You know about that? Can you comment?
So I don't know those data in particular. I know that brain development is clearly very crucial to the subsequent risk and onset of psychotic symptoms. So I can believe that would be something that we ought to focus on. Of course, it's very difficult to do those sorts of prospective studies. It's not something I'm capable of doing in my lab, but certainly that is a period of risk, for sure. Did you have a question?
What are ketamines? Is that the...
Oh, I'm sorry.
Are there many medications under the ketamine category? Or
So
what's ketamine?
ketamine is one drug. it binds to a group of receptors in the brain that they're called NMDA receptors. It modulates how excitable the neurons are in your brain. And it does so in sort of interesting ways, wherein it may increase the activity of some cells and decrease the activity of others. And crucially, I think why it wears two hats, why it can induce some unusual experiences but make some people with depression better, is that it really depends on the baseline activity of the cells, the effect that the drug has. So it was developed in the 1960s as an anesthetic, but when people were coming out of the anesthesia, they had some really unusual and sort of frightening and disturbing experiences that people noticed were maybe similar to some of the things that people with psychosis reported. But as we've studied the drug over the years at Yale since the 1980s in hundreds and hundreds of people now, safely and reversibly, we've learned that it has all of these other interesting properties that have really sparked, a whole generation of new treatment ideas. Hi.
You had said there were some good responses to the TMS. Were there anything that happened that you needed to pay attention to, things that I'm not quite sure how to ask the question?
Side effects? Sure. So as I mentioned, one of the things that TMS does in inducing activity in the cortex is that induce twitches of the musculature in people's scalps. And that can be quite painful. It can induce some headaches. It can make your jaw twitch quite painfully. So we gave people gum shields. Some people found that to be quite unpleasant and painful. The cognitive data I showed you, we were concerned by changing the activity of auditory cortex where you might actually reduce people's memory capacity, particularly for words. We checked that really carefully throughout the trial once every week, and we found actually that it improved things. But some people did find those muscular effects to be a little bit unbearable and didn't want to proceed. Not everybody.
That was it? Just the actual
The procedure itself.
demonstration of
Yeah.
it, but nothing?
There was no worsening of psychotic symptoms. In fact, as we showed, things seemed to improve.
But anything not psychotic? Any other?
Not that we were able to detect in this context, no. Anyone else? Oh, hi. That's a really great question. I don't have an analysis to show you, but my suspicion is that it works better earlier in the illness. We think that the plasticity that's mediating this effect is much higher in people earlier on, and that over time those mechanisms might change as people have been ill for longer. However, some of these people had been ill for a fairly long time and still showed a beneficial effect. So I think it works best in younger people, but it seems to work quite well for everybody. Oh, hi. Sorry, I didn't even see you guys up there. Hi.
Well, I'm not a scientist, but I can't help, and this may be a very far-fetched question.
I love far-fetched questions.
I mean, I'm thinking, off in the future,
Uh-huh.
there would ever be a chip that would stimulate slowly release in the brain and have some control.
So funnily enough, that isn't that far in the future, and that's something that Dr. Crystal and I are in negotiations with the neurology department to start to try and develop, right? So we do this once a day with people for 4 weeks, but the idea would be to really figure out what's the pattern of neural activity and how do we need to change it in a way that they don't need to come in and see us every day and in a way that may be more sustainable over time. So that's definitely our dream. And with DARPA funding and with collaborations with the members of the neurology department, that's something that we're actually putting into practice. So yeah, thanks for the question.
It would be helpful if you and future speakers could repeat the question.
Oh, I'm sorry. Will do. Hi.
Hi, can you talk a little about what may contribute to the changes in the dorsolateral prefrontal cortex that contribute to the aberrant salience, particularly around trauma, like the genesis of sort of these psychotic symptoms?
So what do we think the neural mechanisms are, particularly in dorsolateral prefrontal cortex, of generating these symptoms? Yes. So what I mentioned about ketamine, its effects on some cells but not others. Activity in the dorsolateral prefrontal cortex seems to be very tightly regulated. It's not good to have that region overactive for long periods of time. It can actually be neurotoxic. And we think that ketamine acts on the cells that retain that inhibition. And by disinhibiting that circuit, people start to attend to and learn about things that they really ought not to. And we think that might be the state, at least early in psychotic illness. So that's our hypothesis right now. We think it's acting specifically on these inhibitory cells, but we have lots of work to do to sort of prove that to be the case. Hello.
Did your studies analyze whether the TMS was equally effective if the psychosis was caused or exacerbated by the use of substances like cannabis?
So nobody in the study could be an active user of cannabis, so we can't actually speak to that directly. They had used cannabis in the past, and some of them quite recently, but we don't have the data on that, I'm afraid.
Wonderful, thank you.
Thanks a lot.